Namaste Betya, Hamisha Khush raho Betya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, JAIPUR. In today's lecture, we are going to continue in the series of diseases of locomotor system. In the last lectures, we have discussed about various diseases of the locomotor system, which included osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and gout. In today's lecture, we are going to continue the present series with pseudo-gout, that is calcium pyrophosphate dihydrate deposition disease, CPPD Crystal Deposition disease. So I believe that you must have gone through the gout and the other topics that we have studied in the classroom in this video lecture. And today we are going to start with a new topic of CPPD Crystal Deposition disease. What is pseudo-gout? Pseudo-gout or CPPD, it is calcium pyrophosphate dihydrate deposition disease, is basically characterized by acute or chronic inflammatory joint disease that is usually affecting the older individuals. So CPPD disease is characterized by acute or chronic inflammatory joint disease that is affecting the older individuals. The knee and the other larger joints are most commonly affected. The crystals are thought not to form in a synovial fluid, but they are shed from the articular cartilage in the joint space. So in the CPPD disease, that is calcium pyrophosphate dihydrate deposition disease, there is acute and chronic inflammatory joint disease and affecting the older individuals. The knees and other large joints are most commonly affected, but the crystals are thought not to form in the synovial fluid, but are shed from the articular cartilage into the joint spaces, where they are phagocytosed by neutrophils and incite an inflammatory response. It is most common in the elderly, that is occurring in 10 to 15% of the persons with the age group of 65 to 75 years of age, and 30 to 50% with greater than 85 years of age. Now, CPPD or the let's again go through the incidence. So in CPPD, the crystals are not, this is an important thing to remember, the crystals are not formed in the synovial fluid, but they are shed from the articular cartilage into the joint space, where they are phagocytosed by the neutrophils and incite an inflammatory response. It is most common in the elderly and occurring around 10 to 15% of the persons with 65 to 75 years and 30 to 50% with greater than 85 years. CPPD is most often an idiopathic, but it can be associated with the other conditions like aging, with disease associated like primary hyperparathyroidism, hemochromatosis, hypophosphatasia, hypomagnesemia, chronic gout, post-meniscectomy, and epiphyseal dysplasias. So there are various, it is usually idiopathic, means the exact cause for CPPD crystal disease is not known, but it can be associated with various other conditions like aging. There are various diseases association seen in case of primary hyperparathyroidism. There is hemochromatosis, hypophosphatasia, hypomagnesemia, chronic gout, post-meniscectomy, and epiphyseal dysplasias. Now, the clinical manifestations of CPPD crystal deposition disease. It can be asymptomatic, or it can be acute, subacute, or chronic. So the cause can be asymptomatic, it can be acute, it can be subacute, and it can be chronic. The acute synovitis is superimposed on chronically involved joints. The acute CPPD arthritis is termed as pseudo-gout because it is striking similarity to the gout. So in acute synovitis, it is superimposed on chronically evolved joints. With CPPD arthritis was termed as pseudo-gout because it is striking similarity to the gout. Acute CPPD arthritis or the pseudo-gout is a condition in which knees are most frequently involved, but it is polyarticular, that is involving multiple joints at a time in 2/3 of the cases. Other sites of involvement include the wrist, shoulder, ankle, elbows, and hands, and also the temporomandibular joint. The involved joint is red, edematous, swollen, warm, and painful. So the joint that is involved is red, swollen, warm, and painful. The most patients have evidence of chondrocalcinosis, that is calcium deposition in the articular cartilage. So in acute CPPD arthritis, that is also known as pseudogout, the knee is most frequently involved, but polyarticular in 2/3 of the cases. Other sites involved are wrist, shoulder joint, ankle, elbow, hands, and temporomandibular joint. The involved joint is red, swollen, edematous, warm, and painful. And most patients have evidence of chondrocalcinosis, that is calcium deposition in the articular cartilage. There is chronic arthropathy. In chronic arthropathy, there is progressive degenerative changes in the multiple joint that resembles osteoarthritis. So in case of chronic arthropathy, there is progressive degenerative changes that are seen in multiple joints, and it can resemble osteoarthritis. There is joint distribution sites which involve knees, wrist, metacarpophalangeal, hips, and shoulders. There is also symmetrical proliferative synovitis, which is seen in familial forms with early onset, clinically similar to rheumatoid arthritis. There is also intervertebral disc and ligament calcification with restriction of the spine mobility. There is also spinal stenosis and rarely periarticular tophus like nodules are seen. So in case of chronic arthropathy, we see progressive degenerative changes in multiple joints that can resemble osteoarthritis. There is joint distribution sites, which includes knees, wrist, metacarpophalangeal joints, hips, and shoulder joint. There is symmetrical proliferative synovitis that is seen in familial forms with early onset, clinically similar to rheumatoid arthritis. There is also intervertebral disc and ligament calcification with restriction of the spinal mobility. There is spinal stenosis and rarely periarticular tophus-like nodules. Now, what are the precipitating factors that are leading to the development of CPPD crystal disease? The precipitating factors include trauma with a rapid diminution of the serum calcium concentrations in severe medical illnesses or after surgery, especially parathyroidectomy. The associated symptoms include low-grade fever and on the occasion, temperatures as high as 40 degrees Celsius and 104 degrees Fahrenheit. There is the leukocyte count in synovial fluid in acute CPPD can range from several thousand cells to 1 lakh cells per microliter, and the prominent cell being the neutrophil cells. So the precipitating factors include trauma. There is a rapid diminution of the serum calcium concentration in severe medical illness after surgery, with especially parathyroidectomy. There are associated symptoms which includes low-grade fever and on association temperature such as high as 40 degrees Celsius and 104 degrees Fahrenheit. The leukocyte count in synovial fluid is in acute CPPD can range from several thousand to 1 lakh cells per microliter, the predominant cell being neutrophils. The diagnosis is done by the synovial fluid analysis. The synovial fluid analysis by demonstration of CPPD crystals, typical rhomboid or rod-like crystals with generally weak, positive, bifringent or non-bifringent with polarized light. There are radiographs or ultrasound demonstrating punctate or linear radiodense deposits within fibrocartilaginous joints. There are various menisci or articular hyaline cartilage with chondrocalcinosis and degenerative changes. The secondary causes of CPPD deposition disease in patient is less than 50 years of age. So how will you diagnose? Whenever a case of CPPD crystals is coming to you, the diagnosis is done by the synovial fluid analysis by demonstration of CPPD crystals, typical rhomboid or rod-like crystals, generally weakly, positively bifringent, non-bifringent with polarized light. The radiographs or ultrasound demonstrate punctate or linear radiodense deposits with fibrocartilaginous joint, menisci, or articular hyaline cartilage with chondrocalcinosis and degenerative changes. The secondary causes of CPPD deposition disease in patient with less than 50 years old. The differential diagnosis of CPPD crystal deposition disease consists of osteoarthritis, rheumatoid arthritis, gout, and septic arthritis. So the various diseases which represents CPPD crystal deposition disease are osteoarthritis, rheumatoid arthritis, gout, and septic arthritis. The treatment for CPPD crystal deposition disease consists of non-steroidal anti-inflammatory drugs, intra-articular injection of glucocorticoids, colchicine, hydroxychloroquine, or even methotrexate may be helpful. There is progressive destruction of the large joint arthropathy may require joint replacement. So the treatment consists of NSAIDs, non-steroidal anti-inflammatory drugs, intra-articular injection of glucocorticoids, we have colchicine, hydroxychloroquine, or even methotrexate may be helpful. There is progressive destruction of the large joint arthropathy and may require joint replacement. So this was all about CPPD crystal deposition disease. Let me revise it once again. CPPD crystal, that is calcium pyrophosphate dihydrate deposition disease, or the pseudo gout. It is characterized by acute or chronic inflammatory joint disease. So there is acute or chronic inflammatory joint disease that is affecting the older individuals. The knee and larger joints are most frequently affected. The crystals are thought not to form in a synovial fluid, but are shed from the articular cartilage into the joint space. They are phagocytosed by the neutrophils and incite an inflammatory response. It is most common in elderly and occurring in 10 to 15% of the age of 65 to 75 years of age, with 30 to 50% of those greater than 85 years of age. CPPD are most often idiopathic but are associated with aging, disease associated with primary hyperparathyroidism, hemochromatosis, hypophosphatasia, hypomagnesemia, chronic gout, post-meniscectomy, and epiphyseal dysplasias. The clinical manifestations, it can be asymptomatic, or it can be, the manifestation can be due to acute disease, subacute disease, and the chronic disease. The acute synovitis superimposed on chronically involved joints with acute CPPD crystals that was termed as pseudo-gout because of the striking similarity to gout. In acute CPPD arthritis, that is the pseudo-gout, the knees are most frequently involved, but polyarticular in 2/3 of the cases. Other sites, wrist, shoulder, ankle, elbow, and hands, and temporomandibular joints are involved. Which are the joints? Wrist, shoulder. Knee is the most common joints. Other are wrist, shoulder, ankle, elbow, hands, and temporomandibular joints. The involved joint is edematous, red, swollen, warm, and painful. So the joint is red, swollen, painful, and warm. The most frequently, they have evidence of chondrocalcinosis, that is calcium deposits in the articular cartilage. Next, we have chronic arthropathies. Chronic arthropathy with a progressive degenerative changes in multiple joints that can resemble osteoarthritis. The joint distribution sites includes knee joint, wrist joint, metacarpophalangeal joints, hips, and the shoulder joint. There is symmetrical proliferative synovitis that is seen in the familial forms with early onset clinically similar to the rheumatoid arthritis. So if it is present in the symmetrical form, then it can resemble rheumatoid arthritis. And chronic arthropathy can be resemble osteoarthritis. There is also intervertebral disc and ligament calcification with the restriction of spinal mobility. There is spinal stenosis with rarely periarticular propitious-like nodules. Next, we come to the precipitating factors. Different type of precipitating factors, which includes trauma, rapid diminution of the serum calcium concentration, and severe medical illness or after surgery, especially parathyroidectomy. The associated symptoms includes low-grade fever, and on the occasion, temperatures as high as 40 degrees Celsius, that is 104 degrees Fahrenheit. The leukocyte count in the synovial fluid in acute CPPD can range from several thousand to 1 lakh cells per microliter, and predominant cell being the neutrophils. In the diagnosis, the synovial fluid analysis with a demonstration of CPPD crystals, typical rhomboid or the rod-like crystals, generally weak, positive, bifringent or non-bifringent with polarized light. So the diagnosis is done by synovial fluid analysis with a demonstration of CPPD crystals. The radiographs or ultrasound demonstrate punctate or linear radiodense deposits with a fibrocartilaginous joint, menisci, or articular hyaline cartilage with chondrocalcinosis and degenerative changes. There is also secondary causes of CPPD deposition disease in patients less than 50 years old. The differential diagnosis consists of osteoarthritis. We have rheumatoid arthritis, gout, and septic arthritis. The treatment of CPPD crystal deposition disease consists of non-steroidal anti-inflammatory drugs, intra-articular injections of glucocorticoid, colchicine, hydroxychloroquine, or methotrexate, and progressive destructive large joint arthropathy may require joint replacement. So this was about pseudo-gout. Let me cover one more topic in today's lecture, that is calcium aspartate deposition disease. All right, so calcium aspartate deposition disease is another crystal deposition disease in which apatite is the primary mineral of normal bone and teeth. What happens in this disease is there is abnormal accumulation that occurs in the area of tissue damage, that is dystrophic calcification, hypercalcemic or hyperparathyroid state, metastatic calcification, and certain conditions of unknown cause. 30 to 50% of the patients with osteoarthritis have apatite microcrystals in their synovium. So this apatite deposition disease is associated with osteoarthritis. There is apatite aggregates. These are commonly present in synovial fluid. Is an extremely destructive chronic arthropathy of the elderly, which occurs more often in the shoulders, that is known as Milwaukee shoulder, hips, knees, and erosive osteoarthritis of fingers. The clinical manifestation includes periarticular or articular deposits that is associated with acute reversible inflammation with chronic damage to the joint capsule, tendons, bursa, and articular surfaces. So there is periarticular or articular deposits that is associated with acute reversible inflammation to chronic damage. So there is acute reversible inflammation. This is important to chronic damage of the joint, capsule, tendons, bursa, and articular surfaces. There is joint destruction that is associated with damage to the cartilage and supporting structures, leading to instability and deformity. There is clinical manifestations which include asymptomatic radiographic abnormalities, acute synovitis, bursitis, tendinitis, and chronic destructive arthropathies. The symptoms range from minimal to severe pain and disability, leading to joint replacement surgery. There is also acute and subacute worsening of the joint pain and swelling. The diagnosis is done by synovial fluid leukocyte count in appetite arthritis that is usually low, less than 2000 per microliter, despite of dramatic symptoms with predominance of mononucleus cells. It depends on identification of crystals from synovial fluid or tissue. There is individual cells. These are small and can be seen only by electron microscopy or X-ray diffraction studies. There is radiographic appearance resembling CPPD crystal disease. The treatment of appetite crystal deposition disease of appetite arthritis or periarthritis is non-specific. The acute attacks of bursitis or synovitis is self-limiting, with resolving in days to several weeks. Administration of non-steroidal anti-inflammatory drugs with repeated aspirations, rest of affected joints, with intra or periarticular injection of the glucocorticoids. So the treatment part consists of appetite arthritis, periarthritis, acute attacks of bursitis or synovitis that is self-limiting, NSAIDs, repeated aspiration, rest of the affected joint, and intra or periarticular injection of glucocorticoids. So today we have completed CPPD crystal deposition disease, that is pseudogout, and also calcium appetite deposition disease. So this was all for today. In the next lecture, we are going to start with fibromyalgia. This session is powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.